Yes, ma'am.
The sun is there.
Thank you for saying that, ma'am.
See who's over there. Great to see you.
Okay, thank you so much for the very kind introduction, for the invitation. I learned that's your first in-person meeting, is that right?
Second.
Second, okay.
Talk
Second, okay. Beautiful, that's wonderful. So I'm Sarah Doss, and I'm here with Erin Loney, who's also in the Ataxia clinic, playing a very vital part as genetic counselor. And I just wanted to talk a little bit about who we are, what we are doing, and I'm also here really to hear any suggestions you may have, anything that comes to your mind, any wishes you have, any ideas. Okay, so the Ataxia clinic is within the movement disorder section at UNMC of the Department of Neurological Sciences. And the one who really put that into place is Dr. Torres Busotto. I don't know if everybody knows him here. He's the boss of the movement disorder section at the Department of Neurology. He had really put in a lot of work to make it possible to have another multidisciplinary clinic among all the other clinics that they have there in the Med Center. So that's really wonderful, and I'm very thankful for that. That's where the clinic is. So we're still just integrated in the general webpage. So if you look at the Clinic for Neurology, let's click to join audio. If I can move that away, or
Yeah, if you just click down, that should go away.
Okay. And yeah, so we're still just integrated in the general web page. And so you can find us here, Neuroscience Multi-Specialty Clinic, Ataxia, among the others. That's the address. And it's in the Clarkson South Doctors Building. And there are two Clarkson's buildings, one in the north, one in the south. And we are right here in the south and right in the first floor. So when you come in, you go to the right, turn to the right, and you're in the clinic.
Yeah, it's playing through your speakers as well, but that's fine.
Maybe it's better now. Yeah, perfect. And yeah, that's the address. But you can easily Google that, just neurology clinics, UNMC, and you will find us. And there are many people involved, many great people. And when you come in, you will see somebody who does scheduling. You will meet Nora Arambeat. She's the MA of the clinic. You will meet Alyssa Nichols. She's the clinic nurse. And you will likely also meet Erin Clifton. Sorry, I don't have a picture yet. She's very new at UNMC. She's very new to neurology and dived right into ataxia, which is really complicated. I'm thankful she's so confident and does that with me. And of course, here's a picture of me. And of course involved, and then Dr. Amy Hellman, since I'm a movement disorders fellow, and Dr. Amy Hellman, she has a lot of experience from the Huntington's disease multi-specialty clinic that she's leading since many, many years, involving many other specialties, and she's guiding the whole process as well, together with Henry Place. And of course, we also have your guys' info in there already. I'm very thankful for these cool blue folders that every new patient gets, and they're very thoughtful and lots of useful information for the patients that we could never talk to them about in their first meeting because we have so many other things to do, right? And then we see here Erin is in the back. I'm happy she came with us, the genetic counselor, which is a very central role. She will talk about it a little bit later. And then, as Elena said, we have physical therapy, and there are different people involved. I'm just picturing some of them you may meet. So Jen McCune, I don't know if somebody knows her. She's very enthusiastic about treatment of ataxia patients. Laura Halls, she's also very enthusiastic and knowledgeable. She's from the speech therapy side. She also does some cognitive screening testing and also looks for dysphagia, which I think is very important for patients. And then we have occupational therapy. So what I'm always interested to hear, of course, in terms of suggestions from you, what else you think might sense to include in the future in the clinic, you know, because every multi-specialty clinic has different specialties, like HD has more social work and psychiatry. What we don't have, then there may be also nutrition. So we can add on more in the future depending on the need that we see. And then I'm also, of course, working on enlarging the network and finding other providers at UNMC that are really good and enthusiastic about taking care of ataxia patients. I'm glad I found Doug Stoller from cardiology, who has expertise in genetics and cardiology and is very thoughtful and enthusiastic about seeing, for example, Friedreich's ataxia patients. And that's not easy. And for some cardiologists, that's very far away from what they're doing, you know, and yeah, they will do the ultrasound, but it's just not the same as if somebody looks at it who is really knowledgeable and follows the patients over some time. And then there's Jenna, our nutritionist. Patients who would like that or we see a need can also be referred to her, and she can then follow up with phone calls, for example, which proves to be very efficient. And there are many other specialties that we involve with referrals. And yeah, there is, as you know, unfortunately for most ataxias, no treatment that can halt the disease, but there's still many other things we can do. And that's basically what I want to say with this picture. And many of these different disciplines, physician, different subspecialties of physician, physiotherapy, occupational therapy, speech therapy, they're involved in different symptoms that patients may have. A little bit about me. So I came, as you were told, from Germany. So originally from Munich, that's where I grew up. Then somehow I went to the Oktoberfest many times, you know, even when I was already for a long time in Berlin, where I studied, where I established an ataxia clinic and did that for many years, including research in this huge city with many people there. And yeah, and then again, I went to the Oktoberfest and I met my husband coming from America there, and this somehow led me to come to Omaha, you know. That's where I found me a little bit later. That's my family, 3 kids. One is not looking too happy. He's trying to be very serious. But I managed to get another picture of him too. It's usually possible after a while. And so a little bit about what I did before. So I did in Berlin the Ataxia clinic, which is in this building. And this was in the setting of cooperations with international, especially European ataxia study groups. So I was working there on studies. So this is like one very recent clinical trial that we participated in. Unfortunately, the drug tested here did not provide a benefit, but it was a very well-designed trial with European participants, which will be published very soon. Then we did do some research on spinocerebellar ataxia type 14. That was like one of our focus because we, looking into that, just also established many diagnoses there and had a large patient cohort. So I initiated this project where then more and more people joined in, and first author is the inventor of the SARA ataxia scale, Tanya, who's a friend of mine. So and there in these patients, for example, we saw that they have a certain MRI feature with hyperintensity of the dentate nucleus, which was not known before, which is interesting, you know, because we do MRIs on all the patients. And it's, of course, good to have some guiding signs there. And another thing I wanted to mention is, so we had in the beginning 33 study participants. And they all came with a genetic report. Here I have a variant in this gene that's causing SCAR14, protein kinase gamma. And then when we took a closer look at that, with all the criteria that you need to use to establish a diagnosis, we saw actually we can only establish a clear diagnosis in 6 out of the 20 different variants, which shows how difficult genetic testing has become, right? Even if you have a test, it's not really sure what you have. And then there were likely benign variants, and there were the VUS, so variants of unknown significance, many of them. So in that project, we then went on to try to use a way to characterize these variants of unknown significance better, and had a cooperation with Italians also living in Germany, Alejandro Giorgetti and Paolo Cannoni, who did protein modeling. So they looked in a model where exactly is the variant in the gene and what does it, what's the function of the protein. And that helped then to characterize better who actually had SCAR14 and who didn't, even though they came with that variant. Then I did, I will just go quickly over this because I think you're probably not so interested in depth, just to get an impression. So we did MR spectroscopy. I know this is done a lot in the USA as well. So I'm always excited to see that. This is when you look at different areas in the brain and measure metabolites actually. So you don't get such a picture here, but in the end you get something like this, peaks and amounts of metabolites that are in the brain. And we looked at this in several studies, and this was one where we included SCAR1 patients, 12 of them, and SCAR14 patients, 13 of them, and compared them and in the different regions. That's a cerebellar region, the vermis, which is in the middle of the cerebellum. That's the cerebral hemisphere on the outer part of the cerebellum, and pons, that's in the brain stem. And you could see that most of the pathology was here in the vermis, a little bit less in the cerebellum. And then in SCAR14, especially nothing out of the cerebellum, but in SCAR1. Then we did a study on dysphagia. So that was a questionnaire study. So we had many patients in the clinic. We sent out 190 questionnaires, got 133 back, which is a really good rate. And in this questionnaire, we asked about swallowing issues and their relation to their quality of life, because we wanted to know how relevant is it, how prevalent, and how relevant is it for patients. And we asked them also what they're eating, food frequency questionnaires, and a lot of other questions too. So what do you think the patients say is their most disabling symptom affecting their life? We kind of wanted to know where dysphagia ranges among all the things that you notice in your life that you bother you. So it was gait instability, and dysphagia was somewhere down there. So it was really didn't seem to be relevant, right? Nobody felt like, oh, really, dysphagia is a big problem I have.
Do you guys know what dysphagia is?
Oh, swallowing issues.
Swallowing.
Good point. Yeah, thank you. Yeah, when you have trouble swallowing, so like you're choking when you eat.
So is this study the one you did for the people with ataxia? 14?
No, this was general, many different ataxias. So just patients with primary ataxia disorders who came to our clinic, all of them.
The third one on there is Dysarthria. Do you guys know what that is? Speech.
Trouble speaking.
Trouble speaking.
Good point. Next time I will.
Well, just because it's not about.
Just like, yeah, many weird words. I love it because it's the same words as in German. So it's not hard for me to transition in that respect. So and then we looked at the patients, and we had one group with patients who had then proven dysphagia, and another group who had no problem swallowing. And then we looked what issues do they have when they have the problem swallowing. And we could see that they do select their food a bit differently, red one. So every time these are more apart, there was a difference, and every time there are little asterisks up there. then it was compromising for them in social situations when they had trouble swallowing. And they still had the same desire to eat. That was not such a big difference, but they had some fear associated with it. And they felt it was relevant when you looked at it this way. So almost nobody said it's their most burning issue, but when you ask specifically, then they did emphasize that. And they also took a lot longer to eat. That's what duration means.
I would agree with that because just from my experience, a lot of social activities revolve around food.
Yeah.
And I am starting to have more and more trouble swallowing. And when I start choking, it's scary to me because sometimes I can't catch my breath, but it's scary for the people around me as well because
So we had we were in England recently and visiting some friends, and I haven't been around her for years. And she started to aspirate just on some spit and some saliva. And I was in a different room, but I could hear her and I knew that's what it was. So I was just continuing on with my conversation, not making a big deal about it. And everybody else in that room was freaking out.
they're literally yelling, they're like, skip it. And it's like, just give me a second, it'll go. But yeah, I can't talk when I'm doing that.
Well, it's good to have somebody who knows how it goes.
Yeah.
And this is just a complicated picture which shows that having trouble swallowing and your quality of life is indeed related.
Yeah.
So we had to put all factors in there. So if you have trouble swallowing, it affects your quality of life. And I also personally found it very interesting because in this question, there was one question about going out to restaurants, and that was a huge difference.
Mhm.
Of course. So people with swallowing issues are really scared to do that. And then we looked also at what they were eating. And with the food frequency question, we could see what types of food they were eating. And if it's more like an unfavorable, not so healthy diet or more favorable, and you could see that patients with dysphagia, so the trouble swallowing, were more on the unfavorable side. And patients who had no trouble whatsoever, they were more eating on the healthy side of things. And then when you looked at the weight in the underweight group, there were more people who had trouble swallowing, and in the overweight group, so they were more underweight, which is understandable. So it really may have a consequence. And then here we also asked when they had weight loss, if the weight loss was wanted, because there are many people who want to lose some weight, right? And I like, yeah, it's great, I'm gonna take that. No, it was here, no. In the dysphagia group, it was not wanted. So everybody said no. And at some point, weight loss can become dangerous or not good for your prognosis if you lose too much weight or too much muscle. So we did another study. You notice we did include a lot of spinocerebellar ataxia type 1 patients in our studies because this is really a thing in Berlin and East Germany. That's where Berlin is situated. That there are the most common scar is SCAR1. Whereas when you look at these big reviews, it's always SCAR3 for Germany and SCAR3 everywhere. But they didn't take East Germany into account, and that's clearly completely different.
It's interesting because I have SCAR1 and I am of German heritage. So I didn't know that.
Yeah.
But
so what we did, we didn't publish that, but you can do a founder mutation analysis with very old-fashioned genetic microsatellite methods. We did that in our SCAR1 patients. And because the idea is that scar mutations, they don't come on new all the time, but usually they're inherited by parents, grandparents, great-great-grandparents, so for a long time. And with this, we saw that there were only 2 founder mutations. And then when you see where East Germany is, it's close to Poland, and their SCAR1 is even more prevalent. So we would assume that it has something to do with that, and that really the separation of Germany made such a difference in what type of mutations you would find. Yeah, so this is also a study with spiders over ataxia type 1. And here we looked at, do they have maybe another reason to lose weight? How is their energy metabolism? Because we did have some patients with this issue that they were losing weight and losing physical strength because of that. And we did blood tests, body measurements, so measuring how much fat, fat-free mass, and then we did energy measurements. So we put them in a chamber, and they could sit there, and we could, it was closed, so we could measure how much oxygen they breathe in and how much carbon dioxide they produce. And this can tell us something about their energy consumption. And our chamber was not as nice as this one. We didn't need a toilet though, because they were not in there so long. But that's a funny one where you can really measure everything. That's not what we did. We just had them in there for 2 hours after an overnight fast. It was a bit smaller. They had a TV, they had a nice chair, comfortable chair, and were advised just to rest there and sit there and not do much. And these were the people with SCAR1 and the controls, so men and women, and age similar. So the controls are always matched to the people with SCAR1 to be able to compare really. And a similar body mass index, which were able to match that really well. And then we saw that really in the people with SCAR1 here, the resting energy consumption. So just by sitting there, they had more energy consumption than the controls. So that's interesting. And here we looked at, are they maybe more active, because ataxia, tremor. But no, when you sit there quietly, the ataxia doesn't come on, usually by itself, right? And here we saw that was like an infrared motion monitor that they had similar.
I've noticed that fatigue is a problem. Is it because we're using more energy just sitting here and doing nothing?
That is, of course, scientifically would need to be shown first.
Because I wondered why I'm more fatigued than other people, but I'm not necessarily doing more. But if I'm using more energy, doing nothing.
That's what I always figured, because it takes more energy to walk across the room. So I figured that's
And
why
we're
it's
using more
hard all the
energy
time.
doing nothing, apparently.
Yeah. And then you can look at certain things like the respiratory quotient, which was also different, and that tells us that SCAR1 burned more fat than carbohydrates. And same here, fatty acid oxidation can be calculated. So they burn more fatty acid. Sounds good at first sight, but in the end, it's not so good. And something like this is associated with weight loss in the future. Well, so it's again time for the New Year's resolutions, right? So let's go back to Omaha. So now we're here, and pretty new still a fellow, and started some first research. So there's one prospective project that I started. So in research, you can either look at records that you have, because there's a wealth of information, or you can start a controlled study looking forward and recruit patients and ask them, would you like to come and you measure this and that? And so this is the prospective study we're doing, and together with Carolyn Kurze from UNO, Department of Biomechanics. I'm glad I found her. She's very experienced, did much more Parkinson's movement analysis before, and now I'm glad I could have her also join the ataxia research, and we're looking at ataxia patients now, and we did get one grant funded from an internal UN collaborative initiative grant. So we will be looking at people with ataxia, how they walk, how they use their arms, and this will be, from my point of view, interesting and using to assess ataxia, and of course in the further future I would like to use that then to evaluate interventions. And she is a basic scientist and is interested in the movement itself.
Are you recruiting for this study or are you set with patients?
Yeah, so this study, yeah, we will recruit patients for this. We're still waiting for the okay from the IRB, which should
Okay.
come any day. It's still set under review up to now, but yeah, so that would be, of course, awesome if somebody wants to participate there.
So if we're interested in participating in the research, we can contact you
Yeah,
or
yeah,
someone, okay.
absolutely, yeah. And yeah, that will look like that you will get sensors onto your body and your feet, near your body, and they will measure you while you are walking or doing upper limb movements, and then use that data to analyze.
Can you use a walker for that as well? Or do you have to walk by yourself?
That's a good point. I think we have that we wanted to start just with 10 people and people who walk by themselves.
Okay, okay,
And then in the next step, integrate more people.
okay.
So we have it very comparable and can have data quickly to get to the next step. And other things I'm working on, and I have like in the pipeline, is just to connect us to the international community in terms of registries also. So there is the Canvas registry. That's a very interesting ataxic disease. So these people have the cerebellar ataxia, but they also have neuropathy. When you have neuropathy, you don't feel your legs so well. So that also makes you a bit unstable, ataxic. And then they also have issues in their vestibular system. The vestibular system is there to tell you where in space is your head. Is it turned to the right, to the left? How are you moving it? So you can imagine if there's also an issue there, it changes also the ataxia. And this is a recessive disorder, which has been found a few years back, is still only tested in one place in the USA, in Chicago. And they find very many patients with that. Recessive means that your parents usually don't have it, and often nobody else in the family has it. And it starts when a median age of starting is 55, so really late. So there are many patients where we thought we would never find a reason why they have their ataxia in adulthood developing, and now many of these people are diagnosed with this disorder. So, but the state of research is still to look at what is this disease, how is it progressing, and then of course interest is always to find ways to treat it. And then also the ARCA, Autosomal Recessive Cerebellar Ataxia Registry, where I've been in from Germany, would be something I would like to join. And yeah, we're all having in the back of our mind that someday there will be maybe more treatments for ataxia. So that's always also a direction. This is a very long road. It's just a slide that shows from discovery of something that may be a treatment, preclinical testing, then all the different phases of trials to approval, post-marketing testing. It is many years. So where we see ourselves is, and I would like to participate in clinical trials, like later clinical trials, phase 3 trials that come on. For this, we will surely still need to have more patients who are interested in this, you know, because to become a trial center, there needs to be a few patients who are interested, so that we can do that. And we also just do our research here in the area before. So we're really also very busy with making a diagnosis clinically, and also looking in research more into that, knowing natural history of the disease, as I said, joining these registries, establishing outcome measure. That's this project I just told you about. Yeah, and when I come here, it does completely make me, I wanted to, at this point actually, diagnosis, I wanted to refer to Erin, and just, she can probably introduce herself because she's very busy with trying to make a diagnosis, and that's very difficult and work in progress, right? So that's what our day is like.
Dr. Doss?
Yeah.
This is John Brooks from Hastings.
Hi, John.
Nice to meet you.
I have one, and I can't get the stupid camera to work, so I apologize. When you say treatment, is that more like for symptoms? Or is that for mitigating it so we can get back to some sense of, normal, where I wouldn't need my walker or possibly a wheelchair in the future?
Yeah, that's a very good point. So there are two basic types of treatments. So the ones that are disease modifying, they must be specific to the reason why somebody has ataxia. So treatments that could slow down the disease. And many people are working on this. There may be one treatment soon coming out for Friedreich's ataxia, which falls in this category. I hope that this will work next year. And there's the other category of symptomatic treatments, which are developed to just treat cerebellar ataxia. And we are also pretty far behind there. It's very hard. So I see myself in terms of developing treatment more in the symptomatic area. And I'm more interested in stimulation methods than medications there. But that's really still a future thing. In terms of trials we would participate, that would be drug trials. And and they are mostly trying to be disease modifying. So mostly trying to recruit specific patients with a specific diagnosis and trying to slow down the disease. And that will then also, of course, hopefully help with the symptoms.
Thank you. Is there any surgery on the horizon that might replace some wrong?
Some what?
Can you repeat that?
Is it all DNA?
Surgery that might replace what, please?
Or is ataxia all DNA?
It's awesome.
Yeah, so there are many different causes behind ataxia. And in many cases, it's in the DNA. And of course, then there are treatments which are directed at altering DNA effects, the gene therapies. So we're not involved in doing that, but there are really great labs in the USA who are involved in this. And in terms of surgery, so what movement disorders neurologists do a lot, they send many movement disorders patients for deep brain stimulation. But so far, this has also not been successfully really used for ataxia. It has been successfully used for many forms of tremor. So there are some people with ataxia who have very much tremor who have benefited from that, but it's really single cases. But it's not something established that will come very soon.
Thank you.
You're welcome.
Can I ask you a question?
Yeah.
Is there any way to foresee if, like, for instance, she might get an issue? Because this with me is my mom, her family, my brother, two of my brothers had an issue. Is there any early way to diagnose?
Well, I think Aaron will address that.
That is really
Yeah.
a
That's a great segue.
Yes, that's Aaron's job, literally. That is right.
Yeah, so like Dr. Doss was saying, my name is Erin Lockney. I'm a genetic counselor at UNMC. And really genetic counselors help individuals and families understand the underlying genetic implication of disease. And obviously when we think about genes, we're thinking about the instructions for our bodies, telling us how to grow and develop. And if there's a change or a mutation that occurs within the gene, then it really disrupts that process. And that we know that there are genes involved with ataxia. And then if there's a change occurring in those genes, then that's what's kind of causing some of those signs and symptoms. So since we get our genes from our parents, we also pass our genes or genetic information on to our children. And so that's one way that genetic testing can be really helpful to know what that might look like for other family members that might not be showing symptoms at this time. So when we think about genetic testing for ataxia, and that's kind of what I help Dr. Doss do primarily in the clinic, is we're really trying to see what is the best test for an individual to help them determine, what's the underlying genetic cause that's causing that ataxia and what type of ataxia is associated with that gene change. Does that make sense? So where genetic testing gets a little tricky, and it's something that we kind of do a lot of digging on our end, is we're currently not smart enough to know, obviously all of the underlying changes that are associated with ataxia, and labs currently aren't the best at knowing, all of that information themselves. So we don't have one test that is able to test for all of the ataxias at one time. So it can take a little bit more of a stepwise approach. But really, ultimately, by finding that underlying genetic cause, that's information that's helpful for other family members. A lot of ataxias are inherited in what's called an autosomal dominant manner, meaning we all receive one copy of a gene from our mom and one copy from our dad. And a majority of the SCAs are inherited in that dominant manner, meaning only one copy of the gene needs to have a change for an individual to be at risk for showing symptoms. So when thinking about future family members, it's really a matter of which one are we passing along to our children? Is it that normal copy of the gene, or is it that one that has that genetic change?
Okay, but at this point, if there was genetic testing and she was doomed to have this shit. I'm sorry.
I don't care.
I'm sorry. There's only one word for it. At this point, there's something that could be done, right?
The genetic testing would really be a way to help empower you and your family to have more information. Unfortunately, genetic testing doesn't tell us exactly when you would develop the condition, what those signs or symptoms would look like, what the severity or the progression would look like either, but it would provide you with additional information and the opportunity to set up or get established with providers that would be helpful in managing your care moving forward.
So can I tell my story real quick?
Yeah, of course.
So personally, I was one of those people that you only had to have one copy go wrong to have the disease. So for me, it was my dad. And so I was at 50% chance to have a problem. I wanted to know because I'm a planner. So in 1994, at 21 years of age, I had genetic testing to see if I was going to have ataxia. I came back, yes, I carry the gene. At 21, I had no symptoms. I didn't start having problems till my mid to late 30s. And so the whole time, I knew I was going to get it, but I could make life choices knowing about it, as far as like not having children so I can pass on, picking a job I could do in a wheelchair, buying a ranch house or something more easily modifiable to walk in. I could make choices. I could tell people I was dating or marrying about it so they knew what their future held. So people are, and I could tell friends and family, hey, in the future, this is going to happen to me. You're going to have to help wipe my butt later. And so, you know what I mean? So people know. but I'm a planner. So for me, it was the right decision because I could make those choices. Other people don't want to know. They want to bear their head in the sand and pretend it's not happening. But I would much rather know and then plan for it than have it suddenly hit and then be like, oh God, now it's happening. I have to make choices
And
to
my job
accommodate
as
it.
a tightrope
Yeah,
walker
yeah.
is no longer valid.
Right. Or a mechanic or whatever, something I would have to use my hands for.
Yeah.
So I picked a job specifically because of it. I chose not to have children because of it. Now there's genetic modifications they can do so you can have children that don't have it. But when I was that age, they couldn't do that, but they can do that now.
If they know the gene.
If they know they have the gene. So if you know you have the gene and you want to have children, they can actually physically pick the eggs that don't carry the gene and then fertilize those. And then you have that baby knowing that baby did not carry
Oh,
ataxia.
yeah, I'm not gonna have a baby, but maybe my grandkids.
Right, exactly. But like for me, that wasn't possible because I'm too old for that. You know what I mean? That happened later. But But that would have been a nice option for me had I been younger and I knew. So there are definitely benefits to knowing, plus knowing gives you the opportunity to be, everyone says, live each day like it's your last. When you know you have ataxia coming, it's a little more concrete to have that concept of, I better travel and do things now, enjoy my life while I'm more physically able to versus later in life.
And I was the exact opposite because my family didn't know what it was. And I started having symptoms from the cradle. And so I wasn't really diagnosed till I was 28. And so that whole time I was looking for a cure. Someday this will be over and I'll be able to start doing stuff then. Now I'm like living at the poverty level, not able to work. So
there are benefits to knowing. It depends on the person.
And I also just want to touch on from some of the experiences that I've seen in clinic, both in ataxia clinic and in other clinics in genetics, is that a lot of people, when they think about, them having a condition and potentially having children with a similar condition, there can be really a lot of guilt associated with that, putting blame and guilt on yourself and making yourself feel responsible for potentially passing that along. But I just want to normalize the fact that you could never do anything to cause or prevent, having a child with a genetic condition. Unfortunately, we don't get to choose the genes we get from our parents, just like we don't get to choose the genes that we pass along to our children. And so knowing that some people can put a lot of extra pressure or guilt on themselves with that process, want to normalize the fact that there's really nothing you could do to cause a child to have ataxia, just like there was really nothing you could do to prevent having a child either way. And so when it comes to genetic testing, it's really a personal decision. Are you similar to the type of planner that wants to know that information and is empowered and validated by that? Or are you the type of individual that might find that to be really anxiety inducing and overwhelming, thinking about kind of the what ifs moving forward? And so that's really when it becomes a personal decision for what works best for you and for your family too. What other questions do you guys have about genetic testing for ataxia? Yeah.
My daughter has some other genetic issues, and I want to see if I passed the ataxia down to her. Does it need to be a specific genetic test that's done?
Yeah, so there are a lot of different labs out there that do genetic testing for ataxia. And typically what that involves is a panel of genes, meaning we're looking at several genes at the same time or under the same test. But what gets a little tricky, as I was saying before, is we don't have one test that looks at all of them at the same time. So we kind of end up having to take a little bit more of a stepwise approach. But if we were to find, the underlying genetic cause of your ataxia, if you were to test positive, then we'd be able to test your children and know, have they inherited that same exact change or did they not? So that would kind of be the process that we typically take in clinic to provide you with more information.
Does insurance cover testing now?
And that was one thing I also wanted to talk about. Thank you for reminding me. Insurance, as you guys are now probably well aware, can be a really big barrier for us, right? We have to obviously go through insurance for genetic testing and get their approval prior to any testing that we do. And that's where things get really tricky. There are some insurance companies that are more likely to cover ataxia testing for us. And there are other insurance companies that are sticks in the mud and give us a little bit more pushback. So what Dr. Doss and I do is we evaluate all of these labs together to see which one is the best for your insurance companies, which ones are more likely to be covered, so that we can ensure that this type of testing would be the lowest cost for you and your family. So there isn't no one blanket statement, yes, insurance is likely to cover testing, unfortunately, but we're hoping in the future that will likely change and become a little bit easier for us.
If you have to pay out of pocket, how much is it?
It really depends on the lab. It can range from as cheap as $100, depending on what your insurance copay deductible situation looks like. Or there are some labs that are looking upwards to a couple $1,000s, unfortunately. And so that's where we kind of fight with insurance a little bit more to put that cost lower for us.
And by the way, I'm going to caveat it by saying Nebraska Ataxia, the grant system exists to help you with any part of your ataxia, including if you're interested in having genetic testing done for your children, etc. You can apply for a grant to cover any out-of-pocket expenses that you would have. Because $100 if you're on disability can really add up.
And just a caveat to that, you need to apply for the grant before you have that testing done. Because once you've paid the bill, Nebraska Ataxia's policy is that we don't give reimbursement for already paid expenses.
Yeah, you have to
So,
get it covered ahead of time.
Yeah.
And then go through it, yeah. Just, and that's for you
No,
guys.
that is
that's
very
good to know.
helpful.
Yeah,
Yeah.
That's a great reminder.
Medicare.
There are, from some of the research that I've recently been doing, a lot of the federal Medicare, like A and B, is more likely to cover genetic testing in certain labs, whereas more of the private or managed Medicare, sometimes we get a little bit more pushback from them, depending on the lab that we go through. For example, one of the labs, GeneDx, is one that we use fairly commonly just in genetics in general. They would offer genetic testing for free for the Medicare A and B, the federal plans. So still variability, and that's kind of part of the conversation that we have together in clinic when determining, you know, whether genetic testing is right for you and for your family too, weighing kind of the costs, benefits, and limitations and that sort of thing.
Yeah, it's a huge jungle. It's changing constantly
Yeah.
what they offer. So I'm extremely thankful that Erin does a fantastic job with that because it's not easy.
the other
do
part
this.
of it is some clinical trials will offer genetic testing as part of joining the trial and no cost to you as part, because to join the trials, they often want to know if you have 1, 8, 5, 3, whatever it is. So they'll actually test you and no cost to get you to join. And you can or cannot know the results if you want to. So knowing the results of that testing is totally up to you as well. It's, you know, they'll test you for no cost. No one will know, like your insurance company won't know about it. And whether you know about it or not is also individual. So,
Yeah. Probably every trial has their rules how to do that.
yes.
I just want to say that just because you have genetic testing done, it does not mean that you're going to know what type of ataxia you have.
correct.
Whether you want to know or whether you don't want to know. Sometimes there just is no answer.
Absolutely, that's how it is. Sometimes you just learn what you don't have. You know, oh, I
Right.
don't
Yeah.
have this, I don't have that, I don't have
Yeah.
that, I don't have that, but
That's
I
right.
don't know what it is. And this was, for example, with this canvas syndrome I was talking about. So these were patients where nothing was found over decades, you know, and we were calling it idiopathic ataxia, idiopathic late onset ataxia. And then suddenly, boom, we find something new.
They're finding new ataxia genes all the time, right?
Yeah,
Because I have one, which is the first gene ever found. But now what are they up to?
at least 48.
48?
Yeah.
Yeah, so. Isn't that crazy?
And that's just the scars.
Yeah,
Well, thank you guys for letting me talk to you a little bit more about genetics and genetic testing. It was really great getting the opportunity to talk with you guys and meet with you too. So I'll let Dr. Doss kind of continue her presentation, and I know food is on the line, so.
So it's basically at the end, I just showed some flashy pictures. Because I was thinking when meeting you that I do miss a bit the people from Berlin. You know, there was an ataxia group as well. And this is Jitka Watzlaw, one of the main coordinators, together with her mom. She also has SCA1, as most of our patients did. And she did here an art exhibition. She did quite a few art exhibitions with other artists together, which was really nice. And yeah, that's everything. That's her mom, Marlise, whose husband also had SCA1, and with her daughter together, she headed the group in Berlin. And yeah, one of their mottos is turn your face towards the sun and the shadows will fall behind you. And also when I read that, it makes sense, it's inspiring. So I always feel we learn from people who have ataxia in very many ways. In this way, how they manage their life, which is not easy, and how they overcome many hurdles, and of course also in an academic, clinical type of way. So we learn something new with everybody who's coming.
And because I missed the very beginning, did you talk at all about your clinic?
A little bit, yeah. I showed some pictures.
So
of
how
people.
often is the clinic?
Okay. It's now the multidisciplinary clinic is once a month on Fridays, and follow-ups. So when you come first, it's good to go to the multidisciplinary clinics to see everybody. And follow-ups are also on different days. So that's more flexible.
How long is the first appointment?
That can take up to 3 hours.
Okay.
Depending who you want to see. So some people are very well established with physical therapy, and they say, oh, I really don't need to see physical therapy, and that shortens your appointment. Some people come and they only want to see genetic counselor and me, really. So that's also possible. But if you see everybody, then I would count 3
I have
hours.
a question.
Yeah.
Dr. Doss?
Oh, just one moment. We have a question in the
Okay.
room.
Okay.
I used to see Dr. Torres, but then he became specialized in like Botox. Is that still all he does?
He is specialized like in tremor and Botox, but also sees some general movement disorders patients.
Okay, because
But he has more and more like administrative things to do. The group is growing, and he has a lot of management and organization, and is seeing less patients.
well, I needed a reference to start going to your clinic,
Yeah.
and I got one, but what I ended up with, they sent me an appointment page saying that I have an appointment with him, where I wanted to start at your clinic. So I wondered if it was because I used to see him, if that's the way they went, or should I call and do that to the clinic instead of him?
I mean, you can also see both, depending on how you want to. You can see, in addition, you can make an appointment for the Ataxia clinic. Call for that, basically make that an addition.
And what number do we call to get an appointment with you?
Yeah, I should know this by heart by now, right? It's on this page, but basically, general number. Here, 402-559.
Oh God, that's tiny. Oh my God. I
Yeah,
can't read that.
that's why I'm saying
Google
this
it.
little.
Oh my God, okay.
Yeah, I'm glad I'm not the only one who can.
559-8600, that's
Yeah.
the
That's
name.
that's what it is.
It's
Okay, and then ask
402.
for
Ataxia.
ataxia gland, okay.
I have a question.
Yeah.
Is
Hi.
that Pam?
Yeah.
Yeah, that's Pam. Hi, this is Pam Wright. Dr. Doss, you probably should be aware that it is very, very difficult to make an appointment for your team. We spent a good month or so trying to get an appointment for my husband, David. And it was extremely difficult. They first we had to have a referral. That was hard. Then we had to send all of our records, and we said, well, Dave is a patient of Dr. Torres, so I think they're there. But they really set up a lot of roadblocks, and he ended up with an appointment in October of 22, which is okay. But from an ataxia family perspective, waiting that long is really hard. And now I'm not even sure that we have a multidisciplinary appointment. So I'm going to have to call back and double check on that.
Yes, because they only make those. That's absolutely
Okay, good.
true. Yeah, and I apologize for that. So we absolutely don't have enough appointments right now, and we will change that very soon. We will add additional clinics. So it probably makes sense to call like in a month to ask for an early appointment. It will be a
Okay.
multidisciplinary appointment. If you already have a provider at UNMC, it's probably the easiest if this provider refers you. So I get many internal referrals, and then you don't need to get another referral from outside.
Well, that was even difficult for the internal referral. So I just wanted to express my frustration, I guess.
Yeah, no, that's very valuable for me. I will take that to heart and we'll try to find better solutions. I know the scheduling is not always so smooth.
Okay, thank you.
I would like to second that. I have literally been on the list since last spring. And it has been frustrating to go, and we've done the referrals, we've done the sending of the records, and going through the extraordinarily fun system of the UNMC touch 1, touch 2, touch 3 phone system. But waiting this long and my appointment is December 17th. And I've called monthly to see if anybody might have canceled, but it is frustrating.
Yeah, I bet. So this clinic definitely does not have enough appointments. So if somebody needs to be seen earlier, sometimes they will have to still be seen by another provider from the movement disorders department. Yeah, I'm also a bit shocked that they gave an appointment in December. As I said, because I'm still a fellow, this was with the scheduling not so easy. So they're basically waiting until I'm completely integrated on the system to open up more appointments.
Yeah, that's why I have my question, because I just saw Dr. Lay, the neuro-ophthalmologist, last month.
Yeah.
And told him I wanted to go to your clinic, and he referred me, and they sent me a letter right away saying I have an appointment next month. So.
An appointment in the Ataxia clinic, or?
Well, see, I thought it was supposed to be with the clinic, but it's directly to Dr. Torres.
Okay.
Oh, no, then it's not.
Yeah, that's why I was wondering if it was the right place.
Yeah, okay, I can see that. We need to open up more appointments. That's actually a great problem to have for us, but I can definitely see that. And I maybe should also try myself to call this referral system, because all I know is how it works is they get, if a referral comes from outside, they get all the records, and then they give the records to, or they look at them and see if it's really ataxia or which clinic it fits into, you know. And if they feel it fits into the motor neuron disorders clinic, then they will have the patient go there. Or if they feel it fits into tremor, then it's another clinic, or stroke. So they have different clinics. So.
Welcome to the US medical system.
Yeah.
Yeah, they don't want that free stuff because that's like hard to use.
Dr. Doss, I have Canvas. I'm scheduled to see you in September. I've been seeing Dr. Piccione, and he thought I should come and see you.
Great.
We have a Facebook group of Canvas patients from all over the world, and there's about 85 people in it. So if there's any research, there definitely will be people interested in participating.
Yeah, there is. Maybe, how can I contact you?
I'm in the Nebraska Medicine, and I am seeing you in September.
Okay.
And I can try and message you in the Nebraska Medicine app.
Yeah, so there's an international study on Canvas, which is supposed to start in January. And
is that in London?
It's also in the UK, also in Germany, also in Australia, also.
So we have people from all those countries in this group.
Yeah, that's awesome.
So that would be awesome.
Okay, so
yeah.
Them first. US center.
Okay, I think I'm scheduled to participate in the one in London because I had my genetic testing done at U of Penn, and they asked if I wanted to participate, and I just signed a release.
Okay. Okay.
Thank you.
Very welcome.